Thank you very much. It looks like Mpumalanga is now ready to give us a presentation. Over to you, Dr. Mlondo.
Thank you. I'm going to present experiences of Mpumalanga province in tackling the virus last year. Just for those who are not familiar with our province, it represents 6% of the total land area in the country. We also have the borders of Mozambique and Swaziland. And we have a population of about slightly more than 4 million people. We are dominated by the demographics is Africans, mostly Africans, and then there are whites, 5%. Coloreds and Indians are below 1%. In terms of the economy, Mpumalanga is the 4th largest economy in the country and is rich in mineral resources like coal. And we are also home to manufacturing production. Some of you will remember that we have Sasol 2 and Sasol 3 in the province. And we also have the largest or 3 of the biggest power stations in the Southern Hemisphere. We all have all that in the province, but that does not mean that we have endless power. No, we also experience load shedding like everybody else. In terms of the public health system, there are 32 public hospitals. There are 3 districts in the province. There is Ehlanzeni, there is Harisibande, and there is Nkangala district. It's a small province. Ehlanzeni, in Ehlanzeni, there are 13 hospitals. In Harisibande, there are 10 hospitals. And in Nkangala, there are 9 hospitals. Now and again, our Executive Council, they commission such studies that we assess the functionality of public hospitals in the province. We've done that a number of times. We've done it 3 times, actually. So the information or the findings have helped, so that there is we could tell where there are shortages, where in terms of equipment, what had to be bought, where, in terms of staffing, where were the critical areas. In conducting this case study, we were assisted by a VEX team. And in terms of methodology, it was desktop research mainly, reviewing reports from, we got the reports, disaster management, but they got those reports from departments. Because the departments were reporting almost daily on their experiences. The team that was doing the research, they also reviewed other documents, mainly from the Department of Health and other sources, and also from their sources at WITS. They also conducted one-on-one interviews to validate some of the information that they had gathered. The officials that served as key informants were mainly from all departments and some from the municipalities. It was mainly the COVID committee, the finance, some executive managers, just to indicate how the APPs were affected by COVID. And then, there was also a request for very sensitive data, which at times was not easy to get from the Department of Health. And it was not even ethical for them to release that information. But some of the information was obtainable. Then the researchers had to analyze that data from the Department of Health. In terms of findings, that the province experienced its first case on the 9th of March. And since then, up to the 9th of November. Why the 9th of November is because this report had to cover that period. We had to submit by the end of October, and then we requested for extension. So the work, as reflected here, goes up to November. And out of these, there were 96% recoveries. The active cases were 1.5% at that time, and the fatalities were 2%. By the 30th of October, we had a total of, well, that's nationwide, 723,682 cases, with the majority of the cases coming from Gauteng and Western Cape. Those are it's not Mpumalanga figures. But in the province, we had 28,763 cases. You can note from these findings that there was the epidemic was more delayed. And also that, within the first 3 months, April, May, June, the figures for the province were 15, 39, and 89. Whereas in the other provinces, the figures were quite high. But that should be viewed against the total population of the province and the fact that the other provinces are economically dense. I mean, there are many people there. The findings also relating to deaths is that I've indicated that we lost 610 of the population of Mpumalanga by the 9th of November. And of these deaths, 275 were females, 335 were males. What was noted was that with regard to the deaths, the majority of the cases is those that were elderly. And then the COVID-19 deaths were the highest, almost all over the country, during level 3 lockdown period. And for the patients who died, the median time from the time of diagnosis to death was 11 days. And that what we picked up was that most of the comorbidities were done after the person has passed on. I'm still continuing with the findings here. The cases is those that are indicated in blue, the recoveries in orange, and then the deaths is gray. In terms of the cases, you can see the months at the bottom. In August, we were at our peak. It's almost everybody, but out of the total statistics in the country, Mpumalanga statistics comprised 8% of cases. They comprised 7% of recoveries and 7% of deaths. Recovery rate by age. You can see from this diagram that, from the graph here, that the older you get, the chances are you are not likely to recover. But the younger you are the likelihood of recovering is greater. And it's mostly people who were 80 and above who passed on. Deaths by reported comorbidities in the province. Most of them is obesity, 555. We said the total number of people who passed on from up to 9 November, the total number was 610. Those who passed on and who were found to have had diabetes was 335, hypertension 316, obesity is almost everyone, 555. HIV 546, TB also almost everyone. And then there were some of the comorbidities that could not be listed here. What worked well for Mpumalanga? On reflection, we note that the Provincial Command Center helped a lot. It was led by the Provincial Cocta Department. They ensured that the response to the pandemic was multi-sectoral. All the departments, the municipalities, and other key stakeholders were participating, and they were all coordinated from the center. We also note that the response rate, the primary response from the department of the province, they prepared a strategy that was, we call it was robust in the sense that they went to the communities, the premier, the MEC, the executive leadership. They coordinated a strategy where all the CTW workers in all the wards, we have about 400 wards in the province. It's 18 local municipalities. The CTWs had to work with they have a direct contact with the municipal, with the population or the community in their wards. They report to the councillor, the ward councillor. So information about someone being sick in Ward 1 will be communicated to the councillor of that ward, and it would move up quickly to the mayor, to the Department of Cocta, and will reach even the center where all the information was coordinated. So it was easy even to coordinate the need for washing of hands, for social distancing, for the wearing of masks, to conduct education programs in the communities. We are a rural province. It's easy when people see, we rely a lot on the word of mouth. When people see the CTWs, people who are visible there, telling them what to do, because everybody was panicking. It was a new experience, and we're told that we're going to die if we don't comply. The other thing that worked well was the support from the National Department of Health and the WHO. The province, the Department of Health also got support from Right to Care and from Broadreach, especially in terms of getting information and formatting it the way it was required and submitting it to the central database, to the National Department of Health. Other thing that worked well was the reprioritization of activities, particularly the non-salary items in all departments. I indicated that the annual plans, some of the activities had to be put on hold. It was an emergency for everyone. And also the budget was released so as to buy equipment for the field workers and even those that were regarded as essential workers in the departments. There was also a need that was picked up by social development, especially the need, because some people were like domestic workers, No, at times the electricity, it gets dark and one has to ensure that the lights are on. What happened is that the Department of Social Development identified families that needed food because the breadwinner was not working. For some reasons, there was no food. So the department had to identify the families, do the assessment, and submit that information to the center. The center is at the Disaster Management Center, coordinated by COCTA. And then the Department of Agriculture would get what is required. They provided the food parcels. They had to go out to the agri-hubs in the province to get food. And then the food was then delivered by COCTA in assistance with social development to all those families that were needy at that time. What do we need to do differently? We think that there is a need to propose a rotational system amongst health care workers, because as they got infected from handling the patients, then they had to go into isolation, and then the numbers were minimal. And that was a problem. And those that were there were fatigued. And when you are fatigued, you cannot fully concentrate on what you are doing. So there is a need to think fast and to ensure that there is a rotational system that works well. Also, the department has realized that there was a need to have respirator masks that comply with the specifications, because we had service providers that were springing up. It was an emergency, and some really were providing even the sanitizers that were not up to scratch, that didn't meet requirements. So it was a learning curve for the province. Also, the donations that were received were not based on need. Some of the donations, others were based on need, but you spend a lot of time handling a donation that really doesn't meet your requirements at the time. We also felt that we need to establish a reporting system of all COVID-19 health activities done at the port of entries. I indicated in my introduction that we are bordered by Mozambique and Swaziland. And there was a need to ensure that transition at these ports is smooth. And also there was a shortage of staff, shortage of PPEs at those points, and even the fake selling of certifications where people would, just because they want to pass on to get on to the country, you find that what they produce is not acceptable documentation. So as a learning curve, we will ensure that now the people officials who man our ports, they meet the requirements, and also it's people who can ensure that everything is done according to book. The shortage of staff at border posts, that we've taken care of. Now, when it comes to all the hospitals in the province, they need to budget and buy quality sprays, or I've spoken about that. But also, when there is a case that has been identified, there is a need to fumigate that environment. At times, those sprays that are used for fumigation purposes don't meet the requirements. And so it has been established that there has to be a strict adherence to the requirements, and to ensure that the departments don't get a road deal. A proper reporting of COVID-19 deaths from health facilities, home affairs, and funeral undertakers. No, there has to be a proper reporting system, because at times the information gets lost. The other thing that we feel that we could do differently is a organized coordination, because there has been cracks that have been identified. And fortunately, those have been tabled, and now that we are aware of those cracks, we'll handle it differently. Increase human capacity in all testing labs, and invest in IT infrastructure. That is a big one, because you cannot, in an emergency, you cannot only rely on manual handling of information. I'll quickly go through this. The readiness assessment of quarantine and isolation facilities. Perhaps it can be remembered that some of the facilities were not up to scratch, and some were even aired on TV. So that was a learning curve, and we will ensure that those facilities are really proper to house the people who are isolating. The long-term planning for isolation units in all hospitals to increase high care beds in the high care units, yes, because the equipment was running short. And we've also noted that all the positive cases must be isolated and quarantined at a controlled environment, because some of the, I don't know whether they are called patients, people who are isolating, they don't want to adhere to the protocols that are required. Whilst they are isolating, they say, okay, I'm going to isolate at home, I'll quarantine at home, but then they don't stick to what is required. So the province will have to find a way of handling those, or of monitoring them, that they don't escape us. Utilize all available transportation for confirmed cases. What we learned was that at times the EMS will not be available to transport the identified cases, or those that have been confirmed to be positive. And then there will be hesitation. Now the EMS is not available. Can we use this type of transport, or it must strictly be an EMS transport? So now it was finally decided that no, there's no way we can only look at the available EMS and leave it there, but use all available transportation cases with the equipment. This one is ongoing, and we hope that at a certain point it will be ascertained that with the third wave coming, we will be able to transport all the cases that require transportation to the hospitals. The appointment of district and provincial infection prevention and control, so that this is standardized. It came up that there's a need for this, but it was not standardized, and now it's going to be standardized. And also the people who are doing infection prevention, they are going to be trained at district levels to ensure that there is standing training that is happening, so that we are better equipped for the third wave. Where we aim to create an operational SOP, or standard operating procedure, that defines the integrated response activities to be carried out by the different pillars in the community, so that everyone will know what to do when an emergency happens. To restructure the staffing during pandemics, to minimize the disruption of programs. This one is related to the one I spoke to earlier on about rotating the healthcare workers in such a way that the standing programs are minimally disrupted. We also feel that there's a need to strengthen teamwork within the sub-districts and to integrate the hospital and primary healthcare centers so that the staff can be utilized for or to maximum benefit. The department is also mulling on the payment of overtime so that to make it attractive for people to go the extra mile. The vacant posts, they are being filled as we speak. What do we recommend? The recommendations is that we create an attitude of service delivery among health personnel and other disaster management practitioners that are adequately trained to deal with pandemics and other disasters. This does not only relate to the Department of Health in the province, but to all public service officials. We want to put in place programs to address the levels of behavior change in general public in times of challenges. This is work in progress. To focus on improving provincial response and systems resistance to any future shocks, and that the province should improve on leadership and governance, given that the province is the link between, it's national, province, district, and local. But that one is addressed by the Disaster Management Center. It's just that it has to be, the communication has to be improved. We seek to educate senior decision makers in the province on the role and responsibilities of disaster management or in biological hazards associated with pandemics, so that we always know that now and again, these pandemics do occur. For instance, the waves, we don't know how many waves are going to be there. These experiences are just for wave 1, not wave 2. When wave 2 came, we had submitted this. But now we are learning along the way so that when these waves come, we are better equipped. We want to have a systematic approach to emergency procurement so that we don't flout procurement procedures. Thank you. Okay.
And with the previous presentations as to what are the key success factors, there are some questions. Earlier in the presentation, you mentioned one-on-one interviews. Who actually conducted those interviews?
Okay, should I answer now or later? Now,
Please answer now.
Yes, I indicated at the beginning that we were assisted by 2 academics from VETS. They also got someone from HSRC. So it was the team that was doing the work for us. They conducted the interviews.
All right, thank you. Another comment is, it's interesting how DSD identified families who desperately needed food parcels. Is that still going on?
I'll have to check that one. But during this period, the need was greater. But now and again, that happens. DSD is the department that looks after the destitute or people who don't have, who are disabled and so on. They are our social welfare department. Normally, when there are no pandemics, they do support these families. But during this time, there were many people who were sitting at home, who were not going to work. And so there was no income coming to there was no bread on the tables, and they were doing this work.
Great. All right, thank you. You also highlighted how you had to pool resources to some of the activities that maybe at that time were not seen to be an emergency, so that you channel those resources to addressing this emergency. But what is the downside of pulling resources from other activities to channel them towards addressing the emergency?
The downside is we don't meet our targets. I mean, we are bureaucrats. We want to say my target was 80%, now is 40%. So it will be interesting to see the annual reports that are going to come out. Yes, we had to scale down on some of the activities, some major projects that were going to consume the budget. It was rechanneled to PPE, to other emergencies.
Okay. All right. So when you're conducting that process, do you do that in collaboration with your stakeholders who earlier perhaps had some expectations regarding those activities that are now being deprived, if I may use that word, deprived the necessary resources given the emergency? Are they on the same page as you are when it comes to adjusting the targets?
Yeah, this one would not be really the correct one to answer, but especially the ones that are servicing the communities, one would assume that that is communicated and even to the legislature, that some of the projects had to be rescheduled.
Okay.
About the communication, can I shelve this one if there's an opportunity to come back to it?
Okay.
I'll come back.
That's fine.
Yeah.
But I guess Mr. Godfrey here wants to comment from a national point of view, knowing that the resources have to be pulled out of other activities to be channeled to this emergency. Perhaps there was a coordination of some sort.
Yes. Yes, there was a coordination. It was, I mean, the OTP is the nucleus of the province. It was well coordinated.
Oh, all right. Thank you.
Yeah.
Yes, Mr. Godfrey.
I mean, thank you very much for the presentation. The kind of coordination, call it anything, at a national level that happened in a big way. I think the tabling of the budget, the revised budget by the Minister of Finance, I think that gave a big directive to everyone across government, all structures across government, that this is what is going to happen. It was flowing from a series of engagement that led there to say there is a crisis, there is a need to reprioritize across government, and that permeated the rest of government. About departments and provinces were had to revise their plans, had to relook at their priorities and adapt their approaches. That is the major intervention that was done. And then the result of it is that certain activities had to be delayed, certain activities had to be scaled down, some unnecessary activities had to be stopped in favor of interventions that needed to be mobilized at the time. There are some very interesting points that you are making from your presentation, which are I think are important to note from the province of Mpumalanga. I'm not so sure how unique they are, whether they do apply to other provinces. For example, the issue of healthcare capacity. There are 4 points that you made in relation to a need to boost or build the healthcare capacity. Firstly, the capacity of testing labs. I think that's I suppose that would be a national, whereas it's noted in your presentation, it might be an issue that applies across the provinces. The second one, the issue about IT infrastructure. I mean, we've noted in the Northern Cape, there was a talk about a access to e-health, e-education, and e-government. I suppose that also cuts across. The third one that you're mentioning is the filling of vacant posts. One would expect that that would have been prioritized during the time of crisis, that if there were vacant posts, and then the critical gaps, and then there is funding made available, administrative processes will take hand to make sure that those posts are filled, especially on the healthcare workers front. That would have been very, very important to do. The fourth one, in line with that, is the point you're making around a readiness assessment of the facilities. Although here you were talking about the quarantine and isolation facilities, even now with the vaccination centers, it's important to make sure that these facilities, they are assessed for readiness, and there is constant spot checks to make sure that they are even performing as expected on a continuous basis. So those are very important points around healthcare capacity. Then the two other issues that comes very strong in your presentation, which are to do with the mischief at the border posts. I don't know how unique they are to Mpumalanga from other provinces that had to deal with the border posts. What is their experiences in that regard? The reporting of deaths, COVID-19 death, proper reporting of COVID-19 deaths by the Home Affairs and also the funeral undertakers. Quite an interesting one in terms of what exactly was happening, but also whether these kind of issues, mischief, were spotted in other provinces. Thank you very much.
Thank you very much for those comments and the key highlights. The last question is regarding the comorbidities that you have highlighted, the top three being TB, HIV, and obesity. Now, going back, perhaps now we're moving in too much into the health aspects, but what strategies or plans are being put in place to address those issues, the comorbidities that have been highlighted?
Yeah, I was going to have my colleagues from the Department of Health to be with me. Unfortunately, there was a held up elsewhere.
Okay.
So I won't be competent to respond to this one. Yes.
Come back later.
No, that's not a problem. Thank you very much for those insights, and for you, Mr. Godfrey, for giving us the highlights of the key points, salient points from the presentation. At this point, we'll take a 30-minute lunch break, and then we'll continue the presentations afterwards. Thank you very much.
Thank you.
Great.
Okay.